Good afternoon, everyone. Thank you so much for coming today. Heart disease is a leading cause of death for both men and women, but for the past 30 years, there have been more women that died of heart disease in this country than there have been men. Despite this, women are often understudied, undertreated, and often met with skepticism when they present to healthcare situations giving their symptoms. There's more. Many women don't even realize what kind of risk they're under. That's why we're all here tonight. We're so grateful to the Barbara Streisand Foundation, the David Geffen School of Medicine, UCLA Health, the RAND Corporation, and Women Heart West Los Angeles Support Group for making this evening possible. I'm Dr. Carol Watson. I'm director of the UCLA Barbara Streisand Women's Heart Health Program. I'm also a cardiologist, a researcher, a clinician, and even more. I'm a woman. I'm a daughter. I'm a niece. I'm a granddaughter. I come from a long line of powerful, amazing women who died far too young from heart disease. We're all here today because we refuse to continue to let that happen. I'm so happy to introduce my colleagues joining me today. First, I have Dr. Chloe Bird. Wave your hand, Chloe. Dr. Bird is a PhD scientist and senior sociologist at RAND, where she studies women's health, determinants of gender differences in health and healthcare. She's also professor at the Pardee Rand Graduate School and editor-in-chief of the journal Women's Health Issues. Much of her current work focuses on assessing and addressing gender disparities in the quality of care for cardiovascular disease and diabetes. Next, we have Dr. Tamara Horowitz. Dr. Horowitz is an attending cardiologist and associate clinical professor of medicine and cardiology at the David Geffen School of Medicine at UCLA. She is also co-director of the UCLA Women's Cardiovascular Health Center. Dr. Horowitz's clinical activities include women's cardiovascular health, cardiac imaging, heart failure management. Her research focuses on obesity, body composition, gender differences, and cardiovascular disease outcomes. Next, we have Dr. Marcella Calfon-Press. We call her Marcy. Marcy is an assistant clinical professor of medicine and cardiology and staff interventional cardiologist at UCLA Ronald Reagan Medical Center. She is also one of the co-directors of the UCLA Women's Cardiovascular Health Center and the Barbara Streisand Women's Heart Health Program. Her clinical interests include coronary artery disease, acute coronary syndromes, myocardial infarctions, heart attacks, and coronary angioplasty. Next, we have Miss Elisa Beckett. Wave your hand. Elisa is a heart disease survivor and mother of two adorable children. She is a Women Heart National Board member, Women Heart Champion, and Women Heart Support Network Coordinator, offering education, support, and advocacy for women living with or at risk for heart disease. Elisa co-founded Women Heart West Los Angeles in January of 2012, providing monthly education and peer support in a safe and compassionate community at UCLA. She often participates in public speaking, sharing her own personal story of having heart disease and how she overcame her fear of recovery and set out to help others living with heart disease. And finally, we have Ms. Amanda Daniels. Wave your hand. Amanda is a heart coach, an advocate, and television host. Amanda, also known as Heart Healthy Mom, teaches people through her own battle with heart disease about mindfulness and heart health. Amanda is trained a Women Heart Champion, a spokesperson for the American Heart Association, a motivational speaker, and along with Elisa, co-founded the Women Heart West Los Angeles Support Network. Amanda has appeared on several news outlets, including Extra TV, Good Day LA, Fox 11 News, and more. Thank you, ladies, so much for joining me today. Now let's get started. We'll begin our evening by hearing from two very, very special women. These courageous women have not only survived, but are thriving with heart disease. And they're determined to make sure women have access to any and all information that they need to also survive, prevent, and thrive with heart disease. Amanda and Lisa are founders of the Women Heart West Los Angeles Support Group, housed here at UCLA. Please join me in welcoming to hear their stories. Amanda, please come up.
Hi. First, I want to thank all these amazing people that are on the panel here with me today. It's unbelievable what we've accomplished together, and that we're sitting here promoting awareness for the #1 killer of women, which is heart disease. So once again, another round of applause for these women. And there are so many survivors that come to our support group that I see in the audience, and I'm so grateful that you're here, and thank you as well. Now, I'm Amanda Daniels, and I share my heart story with people. I promote awareness for heart-healthy living, and I also talk about mindfulness. Those are 2 things I'm very passionate about. Now, when you're walking down the street and you meet someone for the first time, or you're at an event, you shake their hand, what first comes into your mind? Your mind starts running of all the different things. You start judging them, their hair color, their race, what they're doing, who they're with. Your mind just starts racing, right? Well, if you were to meet me at a preschool event, for example, would you know that I would be living with heart disease? Is that something that would enter into your mind? Probably not, right? So at 18 years old, I went in to get my wisdom teeth pulled. That was the first time I was ever hooked up to an EKG monitor. As I was coming out of the anesthesia, I heard this huge ruckus around me, lots of noise, something's the matter with her heart, get her mother in here right now. I lifted my head, turned to the left at the screen, the monitor, and all of a sudden it went flat. And I screamed. I said, I flatlined, I'm dead. That's all I had seen, that show ER, right? Well, I'm here to tell you that I did not flatline, I did not die, thank you, because here I am, sharing my story with you today. However, they had just unplugged the leads, so I'm gonna lighten up this situation here a little bit today, because I know that in listening to this, you might get a little freaked out, but it's okay, I'm a survivor, all right? We can all get through this together. So years passed, so I went immediately to my grandmother's cardiologist office. My mom drove me there. Of course, we were both very nervous. We walk in, they did the routine testing, and I was diagnosed with preventricular contractions, which is a type of arrhythmia or irregular heartbeats. Fortunately, I was okay. Years passed, I got to go up north to UC Berkeley, and I graduated. I was having fun in my 20s, dating, trying to figure out a career. And really at that point, I was like, I don't have time to go in and see my cardiologist. However, something within me, within my heart, said I had to go in for that annual exam. I went in, and I was diagnosed with idiopathic dilated cardiomyopathy, which subsequently turned into heart failure. Now, my diagnosis was even more difficult because I had just met the man I would eventually marry. He just told me he loved me, and here I come home with this diagnosis. I was also told that the strength of my heart was too weak, so I wouldn't be able to have children because it was too much of a risk and the medications that I was taking. But fortunately, I had an amazing team of cardiologists, and I have to do a little shout out because I know that the man who saved me, one of the men, his wife is here. So Dr. Fowler, just a wonderful team of cardiologists that are here at UCLA, thank you. They saved me along with the support system of my family and friends and research really funded by organizations such as Women Heart, American Heart Association, and now the Barbara Streisand Women's Heart Health Program as well. So I'm a survivor. And I always use this quote, and it's T.E. Kalem. The heart is the only broken instrument that works. Now, I'm here to tell each and every one of you that I've been through it. I've been there and I'm back. And my broken instrument has brought beautiful music into my world. And so if there's a few things that I hope that you will take from tonight, it's 1, talk about heart disease, open up the dialogue, talk to everyone in your life about it. And number 2, when you meet someone for the first time, when people come into your life, think twice about starting to judge them, because that's about being mindful. Be mindful, be more kind, not only to others, but to yourself as well, because that's really heart healthy too. So thank you. And this is Elisa Beckett, who co-founded the Women Heart of West Los Angeles support group with me, and I absolutely adore her. So.
Hi, I'm Elisa. I want to thank you for inviting me to this program and allowing me to share my story with you. I am also the face of heart disease, and I am here to tell you my story. I was 36 years old when I had just delivered my first child, a healthy baby girl, and as I was leaving the hospital, I was having tightness in my chest and trouble breathing. And the cardiologist, or excuse me, the OB who was there told me that it was just basic symptoms, normal due to trauma of delivery and just having a child and not to worry and to go home. I had no prior health complications or anything like that, so I was very excited to go home with my new family, and I left the hospital. And my symptoms worsened at home, and I became unable to breastfeed and take care of my baby. I couldn't sleep because I couldn't breathe when I was lying down. I became very sick. I had shortness of breath. I had trouble walking from one room to another. I was really struggling, and I felt something was wrong, terribly wrong. So my husband and I took our 3-day-old baby to the ER. And I was diagnosed with asthma, and I was sent home with inhalers. I had never had asthma before, but I was thrilled to have some kind of diagnosis with what was wrong with me, and so I was happy that there was a remedy. And after arriving back home, several more days passed, and my condition worsened, and I went back to the ER in hope for more answers. And at that time, I had blood clot testing, and I remember I wasn't able to hold my baby for 24 hours or even be in the same room as her because I had had radiation involved in the blood clot testing. And at that time, the second time at the ER, I was told that I had postpartum depression and that I should go see my OB, that there was medication that I could take for my anxiety of being a new mom. So I went to the OB finally in desperation, and I remember struggling getting to her office from the car in the parking lot to her office. I had trouble walking there. I was completely out of breath, really fatigued. I hadn't slept for, I don't know, maybe like a week or something. And it was then that I was finally recommended to have my heart looked at by a cardiologist. And fortunately, I was in a hospital, and there was a cardiology office there, and I went and was diagnosed immediately with congestive heart failure. So I tell you the story because as women, we are most at risk for heart disease. It's the #1 killer for women, and it is more deadly than all forms of cancers combined. No one thought my problem was heart-related. I had no known history of having heart disease. I was healthy, like Amanda. I didn't have anything wrong with me. People didn't think, no one thought to check and to look at my heart. I was young, I was healthy, and I was misdiagnosed. I urge you to listen to your body and to your intuition. Don't underestimate your own inner voice. Most importantly, learn the signs and symptoms of heart disease for women, which are very different from those of men. Share my story with your mothers, with your sisters, with your daughters, with your coworkers. Talk to your healthcare providers about awareness of symptoms of heart disease in women, even with no prior history. When I was sick, I couldn't find a support network or a group of peers to talk to about what I was facing. I searched on the internet, I talked to doctors, I couldn't find any peers or anyone who was going through my troubles. So after my recovery, I co-founded with Amanda Women Heart West LA, a support group offering support, education, and advocacy. And what I've noticed in that is that I, with Amanda, wanted to help other women, but that support group has helped me tremendously. And support really is part of care and recovery for heart disease, connecting with one another through your peers, through shared experiences. Women Heart is a national organization. It's devoted solely to women's heart health. It's a coalition for women with heart disease, providing free support service to women living with heart disease. Thank you.
Those are powerful stories. And when I first met Elisa and Amanda, I was struck by how normal they looked. And I think that was part of the problem. When you walk into an emergency room looking that normal, people don't necessarily pay attention. But heart disease can affect all of us. None of us are immune. Well, this is a great way to start off. So let's begin the conversation. Wow. Okay. First question. Why is it important for women to learn about heart disease? Chloe, can you tell us what the research says about that?
It's important for women to learn about heart disease, in part because we still are operating under this myth that heart disease, that cardiovascular disease is a man's disease. In fact, since 1984, every year in this country, cardiovascular disease has killed more women than men. Women are very aware of the risk of breast cancer. 1 in 7 women eventually get breast cancer, and 1 in 31 die of breast cancer. 1 in 3 women already has cardiovascular disease, and 1 in 3 women in the US and worldwide die of cardiovascular disease. 90% of adult women already have a risk factor for cardiovascular disease. So we need to take this seriously, and we need to change the way it's understood. We also need to address the way the research is done. We're still operating under the assumption that we can do research primarily in men. Women are now included. The big success since when I was in graduate school doing work on the feasibility and desirability of including women in medical research, particularly cardiovascular disease. Women are now included, but they make up smaller percentages of the patients. As a result, we don't usually know whether or not the research findings are the same for women as for men, or how they differ. Yet we know that women's lives are different somewhat than men's lives. Women with cardiovascular disease are older, and they're more likely to be living alone. They have different social risk factors involved. Women's bodies are certainly a little different from men's bodies, and this is true in ways that affect cardiovascular disease. Women also have different cardiovascular disease, as we're going to discuss today, and they have somewhat different heart attacks. So we need to move beyond the idea that half right is good enough and that we can generalize from men, because women are not small men. You may have noticed this already. In fact, even in the big breakthrough that's happened just in the past month or so is a call from the NIH and the Office for Research on Women's Health, a call for the animal studies to include female animals. So I didn't believe I would still be telling this story 30 years later, but in graduate school they'd put up the picture of the white mice and say, even the rats are white and male. So we can't generalize from that. And the third point is we operate under an assumption that the care that men and women receive is similar, is good enough. In fact, we have a growing body of research that shows that women do not get as good care for cardiovascular disease or diabetes, a major cardiovascular risk factor. And as long as we don't routinely assess care by gender, the problem remains invisible and intractable. So you need to know about the risk in order for you and the women in your life to get the care they need, to be able to recognize the symptoms, seek care, and seek answers.
Thank you very much. Elisa, what would you say? Why do women need to know about heart disease?
I think that women need to take their health into their own hands and take charge of their own health, be their own advocates. If you visit a doctor about symptoms you have and you receive a diagnosis that you can't understand, it just doesn't resonate with you, it doesn't make sense, seek other advice from a different doctor. Don't be afraid to ask questions, come prepared, and seek out another doctor to find another opinion. I recall after I was diagnosed with the heart failure, going to a doctor to find out what it meant for the future of me and having more children, and received one diagnosis, and then going to another doctor to get another opinion and receiving a complete opposite diagnosis. And so I called one and said, do you mind calling the other doctor and talking to the other doctor and coming up with some sort of a conclusion that I can comprehend and understand? And about a week went by, and the doctor called me back and said that they had a discussion, they talked, and they agreed to disagree. So I sought out another doctor. And I think just the message is just to be your own advocate, take health into your own hands, and don't be afraid to ask questions.
Excellent. Amanda, what would you like women to know? Why do they need to know about their heart?
It's so important. If you look at me, you really, like I said, you'd have no idea that I'm living with heart disease. And the same pertains to so many women in our support group, young women, old women, women of every shape, size, color, race, ethnicity, everything. And the disease does not discriminate. So I urge you to listen to your heart, listen to your body. We're women. We're so in touch with our body. However, sometimes we disconnect from it. And so I urge you to really start listening to your heart, listening to the signs and symptoms, which we'll talk about later. If you start feeling like something is wrong, something's off with your heart, seek professional care. Go to your doctor. Talk to your friends. Really, it's important because no one else is going to help you. Now, these cardiologists always tell me, or actually it's Dr. Chloe Bird. She says, when it comes to your body, being a woman, and you're pregnant and you think something might be going on with that child, or if your child comes home and something might be going on with the child, what do? You immediately check on your child. Your child is not going to be of any use, you're not going to be of any use, for your child if you don't take care of yourself. So that's what I really urge people, women, men, everyone, to take care of your own heart health and know the signs, symptoms. Know your ABCs, should you be on aspirin therapy, blood pressure, what's your cholesterol, and to know the signs and symptoms and understand what you need to do to educate yourself.
Great. Thank you. Yes. All right, Tamara, can you tackle the next question? Is heart disease different in men and women?
When I tell people that I focus on women's heart health, they often ask me, well, are women's hearts really different than men's hearts? And I'm going to give you several reasons why heart disease is sometimes very different in women compared to men. Number one, as we already heard about, women go through unique stages of life, pregnancy and menopause. And pregnancy and menopause can cause specific heart diseases, which by definition do not affect men. Number two, my second reason, breast cancer. Some of the major therapies for breast cancer, such as chemotherapy and radiation to the breast, particularly the left breast, which sits right on top of your heart, can directly damage the heart and cause long-term heart disease. Number three, size. Women are, on average, smaller than men. And some of the high-tech devices that we use to treat severe heart disease, such as pacemakers or artificial heart valves or implantable heart pumps, are not designed to fit women properly. And therefore, women are at a disadvantage when it comes to these life-saving devices. And number four, I'll give you the example of the common cardiovascular disease of heart failure, which affects 5 million people in the United States, over 5 million people. And men and women have similar symptoms when they have heart failure. The symptoms are shortness of breath, as Elisa discussed, fatigue, swelling, inability to exercise. However, men and women have a very different cause and type of heart failure. When men have heart failure, it is usually caused by a heart muscle that is weak. When women have heart failure, it is usually caused by a heart muscle that can't relax. The kicker here is that while we do have good therapies to treat the type of heart failure that affects men, we don't have good proven therapies to treat the kind of heart failure that affects women.
Excellent. Thank you so much. Marcy, is exercise ever dangerous?
I like this question because the answer is yes, it can be dangerous, but does that ever mean we shouldn't exercise? Absolutely not. It's been proven over and over and again that exercise is beneficial for the heart. It reduces the risk of death, it can actually prolong life. It reduces the risk of diabetes, it causes reduction in blood pressure, reduction in stress. and all those are risk factors for heart disease. So exercise is absolutely extremely important for heart health. There have been some recent news articles about risk of death in vigorous exercise, in case any of you have read some of these studies. It's a shame because those have gotten more publicity than all the potential benefits of exercise. So we do focus on the occasional risk of injury from exercise. And I would caution that there are 30,000 marathon runners a year that complete marathon healthily, and 1 in every 30,000 may have a cardiovascular event. We tend to focus on that one. And in general, I would say that if you are an active person and have no history of heart disease, there's no reason why you shouldn't exercise. The symptoms that you should be concerned about with exercise, including shortness of breath or any chest discomfort, lightheadedness, or dizziness, you should certainly seek medical advice before continuing your exercise program. And if you're not a very active person at baseline and you're more sedentary, I would caution against waking up and running a marathon. I think that seems, but just to caution, if we don't have this problem in the West Coast, but I come from the East Coast, and in the wintertime, you would have the sedentary person go out and shovel pounds of snow, and that would be the person that shows up with a heart attack. So I would caution, if you're not used to exercising, not to start with something vigorous, but to start slowly and do a graded exercise program. It's extremely important in staying out of my hands as an interventional cardiologist. So.
Great, thank you. Okay, next. Really like this question. Tamara, can stress kill me?
Yes, stress can kill you. Let me tell you about a true and frequent disease which affects primarily postmenopausal women. It is called the broken heart syndrome, or stress-induced cardiomyopathy. Here's what happens. A woman experiences emotional stress. It can be a major life stressor, such as the death of a loved one, or it could be an everyday stressor, such as an argument at work. And in response to this stress, the woman feels chest pressure, shortness of breath, palpitations. She feels like she's having a heart attack. And if a cardiologist, such as myself, images the heart, for example, with an ultrasound, it looks like there is a heart attack. The heart is enlarged, it's weakened, and it's not pumping properly. However, a heart attack is caused by blockages in the coronary arteries, which feed blood to the heart muscle. And in this scenario, there are no blockages. If Marcy came to look at those arteries, there would be no blockages. So the question is, what's going on? The heart is weakened by an overwhelming surge of stress hormones that directly damage the heart. This syndrome is life-threatening, and so yes, stress can kill you. The good news here is if a woman goes to the emergency room and gets proper medical care, the broken heart syndrome is reversible.
Excellent, thank you. All right, this is a multi-part question, and actually, I think I would like, who wants to take the first part? I think, Tamara, you want to take the first part? Can vitamins mend a broken heart?
Unfortunately, we have not found any vitamins that can prevent or cure heart disease. There are very, very rare situations where severe vitamin deficiencies can actually cause heart failure. And in these rare situations, which almost never occur in the United States, they occur in starvation, then giving vitamins would cure the heart. But in general, no.
What about supplements?
There is one supplement which may improve heart disease to a minor degree, particularly coronary artery disease and heart failure, and that is omega-3 fatty acids or fish oil.
Any other supplements?
I'm not
No,
sure.
no.
What about you? I don't know about
Well,
any.
I'll take the next part. It says, I've heard that calcium supplements may not be good for the heart. And finally, what are some good sources of calcium? There has been recent data that suggests calcium supplements may actually increase the risk of heart attacks. It's a small risk, but it's a real risk. There's probably been 10 different studies in the recent decade or so to look at this. None of these studies were specifically done to look at heart attack. they were all done to look at postmenopausal osteoporosis. But since they had the data, they said, well, let's look and see what happened to these women's hearts as well. I would say out of the 10 or so studies, about 7 of them have shown a slight but real increased risk of a heart attack. The other 3 studies did not show an increased risk. But what I would say right now is the data suggests that for postmenopausal women who take calcium supplements, there is a slight but real risk of a heart attack. Does that mean you shouldn't take them? Absolutely not. Everybody has to talk to their own doctor about what is their own personal major threat to life. If your biggest threat to your life is an osteoporotic fracture, you probably should be on something, maybe calcium. Your doctor will tell you. But if your biggest threat to your life is heart attack, then maybe you shouldn't. And that's an individual conversation that each person has to have with their healthcare provider. Now, many people, what all of these studies have shown is that there's something different about tablets, calcium tablets, than calcium in food sources. Every single study that's looked at it has never shown any harm from calcium that you get in your diet. So go ahead, drink your milk, eat your ice cream, eat your yogurt. Those are good sources of calcium. Many people ask me, what are good sources of calcium if you can't take dairy? Well, turns out, oops, sorry about that. Can we get back on that? Well, it turns out there are, fortunately, a lot of really good sources of calcium, and some of them are shown here. Obviously, dairy is going to be your most abundant source, but any green leafy vegetable will also be a very good source of calcium. Peas and beans, so green peas or black-eyed peas, very good source of calcium. Tofu, an excellent source of calcium. Salmon, sardines, excellent sources of calcium. Broccoli, very good source of calcium. So there's plenty of different sources of calcium that people can use. Okay, let's see if we can go to the next question. What are triglycerides and how important are they in predicting cardiovascular disease? I run the cholesterol clinic here at UCLA, so I'll take that one. Triglycerides are another type of blood cholesterol, blood fat. Cholesterol is the way our body makes its cell membranes. That's how we make all our hormones. So we need cholesterol just to live. If you get too much cholesterol, however, then you start depositing it where you don't need it, and in fact, where it will do harm. If it gets deposited in your coronary arteries, that can cause a heart attack. If it gets deposited in the arteries to your brain, that can cause a stroke, or to your legs, that can cause amputation. Triglycerides are another type of blood cholesterol. They are related to heart attacks and strokes just like cholesterol is, but less so. They are very, very common in people who have any prediabetes, diabetes, or obesity. In those situations, triglycerides go up greatly. So those are something that we always worry about and something that you should always be asking your doctor about when they check your cholesterol. Are my triglycerides okay? Okay. Now, we're going to go to some questions that we actually asked people to submit. So before we started this, this seminar, we asked people to send us questions either via the internet or call us or give us some questions that they were interested in hearing about. So we're going to talk about some of those. And I will start off this question with a little background. For those of you who don't know, Loehmann's was a very famous discount clothing store that recently went out of business. A dear patient of mine and I were very sad over this. So she sent me this question, and I'd like to answer it. Can the stress of Loehmann's closing cause heart problems? But seriously, can even minor stress damage the heart? Well, I will talk about that. It turns out that stress is not good for the heart. Stress is great for the heart in order to get us out of a dangerous situation. So if we're running away from a tiger, we need those stress hormones, and that's good. But if we don't have any danger we're trying to get away from, all we're doing is whipping the heart with these stress hormones, that's not good. Turns out that stress is really in the eye of the beholder. So even though some of us might consider one thing minor stressful, another person might consider it very seriously stressful. If you look at data from around the world and look at sporting events, every time there's a major sporting event like the Super Bowl and the home team loses, there's a spike in heart attacks around that. If you look at the World Cup, when Germany was playing Brazil and Germany lost, there was a spike in heart attacks around that. When we had our big Northridge earthquake here in Los Angeles, there was a spike in heart attacks around that. So strongly stressful acute events will lead to a spike in heart attacks. Chloe, you have some information and data on more chronic stress. Tell us about that.
When you look throughout the day, the first studies were done on men. They looked at what happens with men's cortisol levels, their stress hormones during the day. And they go up when they go to work, and they're up, and they would drop down at lunch, and they would go up in the afternoon, and they'd come home and they'd go back down again. They started looking at women in the workplace and in the home. And the women, they went up in the morning and they stayed up all day, and they stayed up through lunch, and they stayed up through the afternoon and into the evening, and they go down when they go to sleep. Well, it turns out that in women, our stress hormones don't come down as fast. And that chronic stress, either as a woman trying to manage multiple roles, or men who are in very stressful occupations, and that doesn't necessarily mean highly paid stressful occupations. It can be very low paid stressful work situations or lack of work situations. But people who are exposed chronically to high levels of stress end up having the dysregulation, an inability of their body to bring those stress hormones back down over time. In the same way that if you develop diabetes, your body can't bring your blood sugar back down to normal levels, or with hypertension, where you can't get back down to appropriate levels in blood pressure. It's losing that ability to control things in a normal level. That increase in stress exposure increases your risk of cardiovascular disease, of diabetes. It can also increase your risk of cancer. So it's important to manage stress. Ironically, through doing things like exercise, which is a form of stress, but ideally we're doing it in a way that's constructive. But there are other ways to handle stress.
Yeah, Amanda, will you tell us, you recently gave a very great seminar on stress reduction, mindfulness for the West LA support group. Can you share some tips with us?
Thank you. Yeah, so what I do is I speak to people about mindfulness and heart health, because those are two very important things. Now, as Chloe Bird was talking about, we are going, and as women, we tend to give everything of ourselves to everyone. And sometimes we don't focus on our own selves. So what I speak about is the importance of finding a way to unplug. What does that mean? How do you do that? When you're a mother, you're working, you're taking care of everyone else, you've got the phone right there. It's very difficult sometimes, especially in this day and age with technology, to unplug. So there are different ways of unplugging, and one of the most important things I talk about is the morning routine. Do you get up and scramble for that phone, or the kids are rushing in? You have to find a way to kind of relax in the morning. And I'm not talking about spending, 20 minutes meditating, although I do encourage that. I actually have a routine that's very long and lengthy in the morning. But I'm asking you to start with a minute in the morning, taking a minute to understand, be grateful for a new day, be mindful in everything you do. And you'll notice that as you start being mindful, as you start being present in these daily moments, you're going to, 1, become more efficient, 2, you're going to be less stressed out, and 3, you're going to really start taking care of your overall body and your heart health, and you're going to be more present for everyone else around you. So those are just some things that I teach. Also, you mentioned exercise, getting out in nature, taking a walk, even when and I know that so many people are bound to their computers and they're in the office. So what does that mean? How can you unplug when you're sitting in front of the computer? Why not just getting up for a couple minutes, taking a walk down the hallway, or parking a little bit farther away from your car and taking that minute in that walk to just become present and to be grateful. When I say being grateful, gratitude is not, because I speak to a lot of people who are very sick, right? I'm sick again. This is happening. I not only have heart disease, I have cancer. Someone's dying in my life. When it feels like your entire world is crumbling in on you, and I know because I've been very sick, and I've been there too. You need to find one little thing to be grateful for. You wake up, I opened up my eyes, I have a new day. That's one thing you can be grateful for. the smell of coffee, which these ladies, I guess, will talk about coffee. I don't drink it, but it's not a bad thing, apparently, to drink coffee. So just finding those little silver linings, because they're going to be there, throughout the day. Once you start recognizing them, you'll notice that they're going to start entering into your life more and more. So, and there's one thing that I tell everyone, I'm not sure that I said this yet, you can't change your environment. You just can't. You can only change how you respond to it. So that's just one little piece of advice.
Thank you.
You're welcome.
All right, let's see. Are standard heart tests like cholesterol screening performed as often on women as on men? Gloria, you have some data on that, don't you?
Unfortunately, they are not. When I first came to RAND in 2000, I got involved in some work that was for the CMS, Center for Medicare and Medicaid Services, part of a master contract. And we were looking at the general population, understanding are there gender, racial, ethnic, and socioeconomic disparities in the quality of care, in routine screenings and routine assessments for patients who have cardiovascular disease and those who have diabetes. And we found that there were, not surprisingly, socioeconomic and racial ethnic gaps, but nobody expected us to find gaps by gender in these routine, inexpensive, evidence-based tests where everyone agrees you ought to get your cholesterol screened every year, your blood pressure. You ought to be able to, if you're high on either of these, that ought to be treated. And we need to make sure you actually control it. You lower high blood pressure, lower high cholesterol. Especially around cholesterol, we saw gaps. And this was looking in among people who already had a diagnosis. So it's not about the differences in presentation. Among people who had good insurance and who were seeing a provider regularly. So we were not looking at many of the reasons that often get used to explain away women not getting the same quality of care as men. People only expected to see these kinds of gaps when you look at the surgical interventions, the heroic and most expensive kinds of treatment. Now, we did a congressional briefing around this in 2008, and unfortunately, it hasn't had a lot of impact. And as a result, we went back and looked at what do we need to do to make a difference. And we got a grant from the Barbara Streisand Women's Heart Health Center at Cedars-Sinai, and we did a study looking at quality of care. We focused just on the cholesterol screening among cardiovascular disease and diabetes patients in California in one of the large health plans. And what we found when you look across the state, one possibility is that the gaps are uniform everywhere. Well, it turns out they weren't. When we looked on average, there was a 5 percentage point difference in the rates at which women and men were screened for cholesterol, even among patients with known disease. But it varied across the state. In 79% of the counties, men got better care than women did. In 35% of the counties, that difference was more than 5 percentage points. In many of them, it was more than 10 percentage points. So we're talking about moderate to large gaps in screening, in a routine screening among people who were getting care with insurance and so on. The gaps were smaller when we looked at the diabetes population, in part because we don't have this bias that diabetes is different in men and in women. As a result, you only saw a 2 percentage point gap on average. However, because it's so much more prevalent, that gap means more women went without coverage, went without getting that test than was true for the sample that had cardiovascular disease. The other point is that that gap is larger when you go from, that's just looking at the differences in screening. We see even larger gaps when you look at what happens in terms of getting treated for high cholesterol and actually being able to bring down high rates of cholesterol. It turns out for women on average, it takes 3.5 statins in order to find one that they can tolerate because women have more side effects. But we haven't done a lot of research looking at what are better treatments that we could have for women? What are things that would be more appropriate for women? And one other point, we also looked at are there ways in which care is better? So we looked at are HMOs doing better? HMOs make it their priority. One of their reasons of existence is to be able to provide these basic aspects of care. So they put a lot of effort into doing a good job around screening and treatment. Interestingly, we found that not only did the HMOs produce higher quality of care on cholesterol screening and other measures, they didn't have the gender gaps. we did see those gaps. We saw lower quality care and we saw gaps among the PPO patients. This often shocks people because they make the assumption that they're paying for better care in buying a PPO. You're not. You're paying for choice. And choice sounds like a great thing. Unfortunately, it works like having choice in picking stocks. It doesn't necessarily produce better results. What produces really good results is expertise or having a really good algorithm. And you've got similar expertise. You've got just as good doctors in the HMOs and PPOs. The HMOs have a really good algorithm that they use in order to come back and say what percentage of your patients are getting this indicated screening, what's happening, are patients getting onto treatment. And that works, having that feedback. And these aren't things that you can provide. You just don't have the information or the ability to put those things in place on your own.
All right, thank you. Elisa, did you have to go back several times asking for testing, or were you right away offered it?
No, I agree about the great disparity in care for women. I walked into the emergency room having full-blown congestive heart failure and left with an inhaler, and I really felt like, you know, I wasn't taken seriously because I had just had a baby. So, you know, there were a lot of things happening with my body, and I, you know, knew that something was really wrong, that it wasn't asthma. And then, you know, the second time, going back to the emergency room and being told that I had postpartum depression, which may have been true, but also having heart failure, and just as a woman with very similar symptoms, you know, trouble breathing, tightness in my chest, fatigue, trouble sleeping, those kinds of symptoms are very characteristic of just being, you know, postpartum or late pregnancy. And so I felt like I just wasn't really taken seriously. And I think that's a major problem in heart disease for women, is because a lot of our symptoms related to heart attacks go unnoticed even by ourselves. You'll see a video that we're going to play shortly about how symptoms can be as simple as just numbness in your arm or in the back of your neck, or fatigue or tightness in your chest, not necessarily, you know, throbbing pain in your chest. And I think that those symptoms can go by the wayside.
Thank you. Now, I think, speaking of symptoms, Marcy, what are the common heart attack symptoms in women?
So, you know, the most common heart attack symptoms in men and women is chest pressure in the center of your chest. Everyone should know that, and I'm sure many of you have already heard that. But what's different about women is that women don't just present with substernal chest pain. They can present in all types of, with all types of symptoms, as Elisa was just mentioning. So tightness in the jaw, difficulty, a strange taste in your mouth, the strange sensation in your throat, perhaps some radiation to your left arm, but also to your right arm on the opposite side of your heart, to your back, to your shoulder blades. You can be nauseous, you can feel sweaty, you can feel hot, you can feel like it's a hot flash, and sometimes you just don't feel right, and you can't even really describe it, and it can be frustrating when you're trying to tell your healthcare provider what's wrong, and you just you know, it's just something's not right. So it's very important. I know I have at least one patient out there who knows what I'm talking about, to not ignore those symptoms and to not waste any time trying to diagnose yourself. Even as you know, doctors shouldn't be their own patients. We shouldn't be our own doctors. So if you have that symptom, just go to the emergency room or seek medical advice right away. In heart attack patients, every minute counts. Every minute of lack of blood supply to the heart causes cell death and necrosis of the heart, and can have profound impact on survival. So you go right to the emergency room. You don't stop. I think we have a video of an example of what women tend to do.
Can we play the video?
Which is sometimes we just keep going.
It started out like a totally normal day.
Mom!
Okay, Okay, move objection deadline to the third line after survey. Oh, honey, for when you always use the verb estar. What are you doing down there? Did you finish your breakfast? Ow. Whew. Don't hit your brother. Honey, you have to eat something. Here. Okay, 5 minutes to carpool. Where's my coffee?
You okay, Mom?
Oh, I'm fine. Sandwich orders. What do you want?
Almond butter and jelly.
Spaghetti.
You sure you're okay?
I'm fine, sweetie.
I am so late. Hey, buddy, how you doing? Hey, honey. You okay?
Yeah, I'm fine.
You sure?
Oh, yeah. Here.
Acai, my favorite. See you guys later.
Wear your shoes. Put your shoes back on, please. You know, go help your sister. We're going in 3 minutes. Oh my God, what am I doing? I forgot to cut off the crust. Voila. Shoes on, potty if you need it. Honey, get your sister. Okay, get her. Shoes. Nobody move. I'm getting a dustpan. Oh.
Mom! I think you're having a heart attack.
Honey, do I look like the type of person who has a heart attack? I'm just gonna sit down. I'm totally fine. Don't forget to wear the high socks with the shin guards.
Forget about the shin guards, Mom.
Come on, Mrs. Underdog is not gonna wait. Whoa. Okay. 9. Hi, sorry to bother you. I think I might be having a little heart attack. Nothing really, just some nausea, tightening of the jaw, dizziness, shortness of breath, muscle pain, achiness, this terrible pressure in my chest. Oh, really? They can be here in how long? 2 minutes. Can you make it 10? I thought I had gas. Turns out I was having a heart attack. Heart disease is the #1 killer of American women. So now I take care of my heart, and I tell the women in my life to do the same.
Sounds great, by the way.
That's nice, sweetie, but that's not my heart. That is. Make it your mission to save your life and the lives of the women you love. Find out more from the American Heart Association at goredforwomen.org.
So that tongue-in-cheek, but you would be shocked at how many times something like that happens. The American Heart Association did a survey about 5 years ago where they had a script of a woman having the exact heart attack symptoms. They said, read the script. What if this was you? What would you do? They said, oh, I'd call my mom, or I'd take a nap, or I'd, try to relax. When they said the exact same script and said, well, if this was your best friend, what would you do? Everyone said they'd call 911, but when it was them, they said, I'd make sure I take the dog to the vet, and then I might go get checked out, but we have to learn to take care of ourselves first.
One thing I just want to add about the reason that it's so important and the reason that we're stressing this is that, do you all know what is a heart attack? I mean, what it is basically a plaque buildup in the artery that gets angry. Just like when you fall and you scrape your knee, something triggers that plaque to become inflamed and angry, and your body reacts by trying to heal that angry plaque. And the way that the body reacts, it actually tries to form a blood clot, and that blood clot is what's deadly. And that blood clot that forms can cause a complete occlusion. It's called 100% occlusion of a main branch vessel. And the reason that it's so important is that if you don't come to the hospital right away, your heart cannot survive without blood flow, and every minute counts. So when you come to the hospital, if you're having a heart attack, we as physicians who take care of these patients are expected to be in the hospital within 20 minutes of your arrival. So we get counted on every minute that we, when we're activated, we come in within 20 minutes to take care of those patients. Just so you understand how seriously we take heart attacks, we will bring you right up to the angiography suite and perform angioplasty if necessary to try to restore flow right away, to try to prevent the outcome of heart attacks, which is often cardiac arrest, heart failure, long-term complications of heart attack, stroke, and God forbid death. So I'm just giving you the background as to why this is so important.
Chloe, did you have?
One of the points that you often make is that the other thing that women often miss, and people in general, but especially women, is that when you're feeling pain on exertion and it subsides when you rest, any kind of pain, it's between your nose and your navel. If it's increasing on exertion and it goes down when you're, that doesn't mean it's okay. That means you need to get that checked. This is cardiovascular related. This is a very bad sign.
Totally agree. Go ahead.
Okay, sorry. This is so important. You need to call 911. You need to call 911, okay? We have patients that come to our support group and they do not call 911. Please tell everyone, if you think you're experiencing a heart attack, call 911. Don't drive to the library and drop off your library book and then you're in the hospital and you end up having a heart transplant. I mean, that's another patient too. We have so many stories. Just call 911. And you're not, like she said, I'm sorry to bother you. I think I'm having a heart attack. It's okay to feel that way because we're women. And like I said, we give everything to everyone else. But just if there's a few things that you can take from tonight, it's to call 911 too.
Great, thank you. Another question that was submitted, Marcy. She said, I recently heard microvascular disease can cause heart attacks in women. What is microvascular disease?
Though as an interventionalist I care about the big vessels and blood flow to the heart, the large vessels of the heart are not the only important parts of the heart. The large vessels give branches, and then those branches give branches, and those branches give branches until they get to very, very tiny branches called arterioles or microvascular. And there's a whole network of microvascular system in the heart that helps provide blood flow to the heart. So if you're experiencing chest pain or angina, as Chloe mentioned, chest pain with exertion, relieved by rest, and you go through the steps, which is either you get a stress test and that's positive, or you show up and I do an angiogram and I find a blockage, the cause may be coronary artery disease, but it may be something else. And if you have absence of coronary artery disease, it may actually be a disease of the microvasculature. So it is a diagnosis of exclusion. So we always err on the side of assuming that it's blocked arteries of the main arteries, but it can be problems with the microvasculature. So microvascular disease or syndrome X is a new type of, it's a relatively new disease, and we're learning more about it because it is quite rare, but it does happen more often in women than in men. And it can lead to the same symptoms of a heart attack and needs to be treated and taken seriously. The mainstay of treatment are beta blockers and aspirin and things that are heart healthy medications. But it is a diagnosis of exclusion, and it usually is diagnosed in the absence of main branch coronary artery disease. And there are some tests that we're doing at UCLA, some fancy non-invasive stress tests called cardiac PET scans or cardiac MRIs that are looking at ways of diagnosing microvascular disease in women. And I would just, as Elisa was saying, if you don't feel well and you've been told that everything is fine in your heart, remember that there are other causes of chest pain that are not due to coronary artery disease. And the other one I'll just mention, because it's important under this category of non-coronary artery disease and other causes of chest pain, there's also something called vasospasm or Prince-Mental's angina, which is a different form of heart disease, not caused by the classic plaque rupture or occluded vessel, but rather caused by vasospasm or a clamping down of the artery that is also more common in women and also has higher risk of adverse cardiovascular events and needs to be treated and taken very seriously. So the buck doesn't stop there in terms of coronary atherosclerosis.
Great, thank you. All right. Now, Chloe, do women suffer as many strokes as men?
Have more strokes than men. It's about 6 or 7% of deaths in women are related to stroke. This is about similar to what you see in some of the incidents around breast cancer related deaths. It's a smaller piece of cardiovascular disease, which is associated with a lot of disability. And it's important that we understand the symptoms for women ourselves, because women are more likely to be living alone. You're less likely to have somebody else there to say, you need to act on this. Because once you're incapacitated, there's no one else there to call.
Okay, and I'd really like to make a plug for this. You wouldn't believe the number of patients who had symptoms that might be a stroke and say, oh, I'm just tired, let me go take a nap. Then they wake up with a huge stroke. So I want to tell you the symptoms you need to worry about. Any kind of weakness anywhere. Any kind of weakness in your arms, your legs, your face, anywhere. Any kind of difficulty understanding language or putting out language. So if you're saying something and it comes out garbled, or if someone's saying something to you and it sounds garbled, that could be a stroke. So make sure if any question, you seek medical attention. If you happen to be with someone who you think may be having a stroke, there's 3 things everyone can do. First, you ask them to smile. It takes a lot of muscles to smile. So it should be a nice symmetric smile. If it's asymmetric, any drooping, that's a problem. Then ask them to hold out their arms. They should be able to hold both their arms out and keep them there. If one of them starts to droop down, that means it's probably weak, and it might be a stroke. And then you should ask them to say a sentence. The sentence I like to use is no ifs, ands, or buts. They should be able to understand what you ask them to do and speak fluently without slurring and without not understanding. So make sure, if you think someone's having a stroke, you absolutely seek medical attention. All right.
And with the other case, just because you had those symptoms and they subsided, that doesn't mean it's okay. You still need to get this checked out.
That means it was a mini stroke or a pre-stroke, and the big one could be next day. So,
Yeah.
absolutely.
Take advantage of the warning sign.
And this is our final question, which comes from another dear patient of mine. There was a recent CBS 60 Minutes show on what it takes to live to be 90 years of age. So the question is, a recent TV show said exercise, moderate alcohol, and coffee intake improve longevity to 90 and beyond. Do these things help the heart as well? Who wants to take that?
Carol, I think you and I both felt very strongly about talking about coffee, so which one?
We actually like this research. All the studies, we used to think coffee was bad. And people said, no, it raises your blood pressure, no, it's bad for the heart. In the last 10 years or 5 years or so, there have been probably 15 different studies. They all say the same thing. Coffee intake actually helps you live longer. I was happy about that too, right? So it was kind of interesting. What they did was they took people who take coffee and control for every single thing else, like their blood pressure, smoking, etc. And when you do that, for every cup of coffee you drink, up to 6, I don't recommend 6. Don't go above 6, certainly, but it helps improve longevity. Turns out that we don't know what causes this, because if you take decaf coffee, you get the same benefit. If you take tea, same benefit. Green tea, same benefit. So we don't really know what it is.
But that's coffee. That's not frappuccinos. That's not adding a ton of sugar and a bunch of ice cream. Well, we do know that coffee reduces your risk of depression. We know that it seems to improve blood sugar in people. It can help with some energy lows. So there are a number of different ways that coffee seems to be beneficial, unless it's interfering with your sleep. You need to be able to get your sleep. Part of the way that other things like exercise help is they help you sleep. So you need to have the whole package.
Okay, and we already heard about exercise, definitely beneficial, and moderate alcohol. We don't recommend this to people because there's a problem with moderation in this country, but every single study that's ever looked at it shows that moderate alcohol intake makes people live longer. That means 1 drink, not more, per night for women, 2 drinks, not more, per night for men. Moderate alcohol intake improves survival. I think
One other thing around exercise, because we've talked about vigorous exercise or moderate activity. There's a growing body of research showing that sedentary time is bad for you, even if you're a person who gets enough exercise. Breaking up blocks of sedentary time is really important, whether that's getting up and walking the dog, going and moving around the house, or doing small bits of other kinds of exercise. It's important to not do what we've all learned to do, which is to sit all day in different kinds of activity.
A blog that said sitting is the new smoking. Very powerful.
All right. So now we'd like to hear what questions you all have. So if you have any questions for us, please raise your hand or come to the microphone. Or I think, do we have microphones to pass around? Okay. Well, we have a question there.
Hi, I'm the poster girl for all the things that you said, and I did have many little heart attacks, but thought it was the lady that was sick last night that I caught her flu and got on an airplane and went to Europe the next day. But here I am, so that's a good thing. And also had breast cancer on the left side. Aside from telling oncologists to tell their patients, hello, remember what I told you? Get to a cardiologist and be checked out year to year, which didn't happen for me. What about aspirin? I mean, how important is that? When should people look at taking baby aspirin? At what age? And can that possibly help out?
So the American Heart Association guidelines say that women over the age of 65 should take a low-dose baby aspirin every day. Other organizations like the United States Preventive Services Task Force have different recommendations. They say if you calculate the risk and feel that the risk of having a heart attack or mostly actually a stroke is better than the risk of bleeding from the aspirin, they recommend taking it. I use the American Heart Association recommendation, so my patients who are 65 years of age and older, I recommend an aspirin for women. For men, the recommendations are 50 years of age and older. And it turns out, it's very interesting data. Turns out baby aspirin prevents heart attacks in men, and it prevents strokes in women. So for whatever reason, the two groups of vessels work differently. But baby aspirin is recommended for men over the age of 50 to prevent heart attack, and women over the age of 65 to prevent heart attack and stroke.
Dr. Press had given a list of some of the symptoms for heart attack. The question is there always have to be a multiple of those symptoms? Because obviously some are more serious, or some are more obvious than others. If you have chest pain, of course, that's obvious. But if you have nausea, my goodness, that could be attributed to so many other things. So.
And that's why I say don't try to diagnose it yourself. If you don't feel well and you're feeling nauseous or you're feeling different, seek medical attention. Don't ignore it. And I'm not saying every time you're nauseous, go to the ER, but have a sense of know your body, know yourself, know your symptoms. And it's a very difficult question. When do I go to the ER? And if you're thinking about it, you should probably go. And if you go and it's nothing and you go home, that's okay. But if you go home and then the same thing happens again, well, I went, there was nothing. You can feel some reassurance, at least, that you were checked out for that symptom. But if it keeps happening, go to your cardiologist, see a cardiologist, go to your primary care, figure out what's going on. But the worst thing you can do is just ignore a symptom over and over and over again. And we have to know our bodies. I know women who've had heart attacks. They know my heart pain was back pain. It was nausea. It wasn't chest pain. And I tell them, remember that symptom. If that ever happens again, you come back to me or you come back to the hospital.
And one quick other thing, if you don't mind. I actually take a 325 milligram aspirin every day by prescription from my cardiologist, along with some heart medication. Have you ever seen any long-term effects from years and years and years of taking, or some bad effects from taking that much aspirin?
No, you don't have to take 325. A lot of data suggests that 81 is probably sufficient, and sometimes people take higher doses in certain cases. The main risks of aspirin are bleeding and stomach upset. So if you have a history of ulcer or you have a history of bleeding, then aspirin can sometimes be poorly tolerated, and sometimes we'll prescribe proton pump inhibitors or Zantac or ranitidine to kind of protect the stomach, because if you have heart disease or you've had a heart attack, there's pretty much no way that I'm going to let you get away without taking an aspirin. So I'll give you a Zantac, I'll give you Protonics, and I'll get you through that. But very rare cases, people can have aspirin allergies, and if that's the case, we give other medications like Plavix in patients who are aspirin allergic. But I don't know of any data that shows long-term, for example, risk of cancer or risk of something adverse for over long-term exposure to aspirin. So that's a good question.
Yeah, hi. I had someone tell me to take aspirin to prevent colon cancer. So if that's a problem in your family, maybe that's why they want you to take more aspirin as a non-doctor. But a frequent patient. A couple of questions. I was intrigued. It sounded as though you either have syndrome X or you have coronary artery disease or you have vasospasm. So one question is, can't you have more than one? Okay, that was easy.
Of all the above.
That was easy, okay. And then next question has to do with the problem of fatigue. Today in the car, I heard that it's actually good if you have to take a little nap every day. That's going to help me live longer, which was interesting. But not more than an hour and a half, I've heard. Yeah, I love listening to the news, right? Because then you're going to die sooner. But what if your medication that you're supposedly taking against heart and stroke is making you tired? I've heard that there's a good medication available in Europe that doesn't have those side effects that's now in experimental use here.
Well, I can promise you every medicine has potential side effects. There's no way around that.
That is something that a lot of people complain of, especially with heart disease, fatigue. Okay, and often we think maybe it is the medications. Beta blockers have that side effect. Usually patients get over that. The one thing I want to bring to your attention is something that we're learning more and more about is sleep disorders, and they're very much related to heart disease. So if you're feeling fatigued or feeling like you might fall asleep during the day, you should talk to your doctor about getting a sleep study, as it is prevalent in people with heart disease. And if you have a sleep disorder, it can be treated, and people can feel 100% changed after getting that treated and feel less fatigued. And I've seen this happen many times. It's not the medications, it was actually a sleep disorder. So something to think about.
I'm going to interject.
Just going to mention, I have several different illnesses, and so as Dr. Watson knows, so I'm being treated for that. So that's not what it is. But I've got myasthenia gravis, and I have diabetes, and I get reactions to medications. So trying to figure out what's going on.
It's going to be nearly impossible for
Right,
you.
right.
So
Yeah.
what I would be most acutely in tune to for you would be a change. If you're fatigued and you've been fatigued, always fatigued, yeah.
No.
But get a lot more fatigued.
Right.
Or for
A lot sleepier.
Yeah.
Those sorts of things.
And
right.
just being from the patient side, someone who's been on beta blockers and ACE inhibitors for 10 years now, when I first started taking the medicine, I had to call the doctor because I couldn't even get up. I was so exhausted, and it's an adjustment. So now that I've been on it for a longer period of time, I'm fine and I'm living with it. But as you said, when there's a change and when you adjust the medications, just being on the patient side of things, give your body a little bit more time to adjust and rest and take that little nap. That's from me, not the doctor. But and learn to try and focus on breathing and relaxing a little bit more too, because I know that it can be very stressful when you get the diagnosis and when you're living with so many different diseases as well. So,
what are the risks of leaky valves leading to heart disease? When you have a leaky valve?
Yes, over time, a leaky valve, just to put things straight, everyone's valves leak a tiny bit. I read echocardiograms, which are the ultrasounds of the heart, and almost every valve leaks a tiny little bit. So if you've been told you have a leaky valve, it may be completely normal within the normal range. If it's in the more moderate to severe range of leakiness of any of the valves, it can cause the heart to enlarge over time or start to not function properly. And when that happens, the heart valve can normally be replaced. And more, the good news here is that we're being able to replace some of those valves without doing the open heart surgery, without cracking the chest.
I'm sorry. Yeah, your question was risk factors. It's really bad luck. The apparatus that makes the valve open and close can be just loosened from over time, and nothing you did, nothing we can actually. It does not.
Leaky valve, Dr. Horwich was saying, leaky valves can cause heart failure, and hopefully we replace them or fix them before you get heart failure. That's key. So if you have a history of a murmur or you've been told you had a leaky valve, you should see a cardiologist at least once a year and most times get an ultrasound every year to look for progression of that leaky valve and prevent heart failure. Because once the heart is weakened, the cat's already out of the bag. So that's key. The second issue of valves is not just the leakiness, but is the stenosis, or the tightening of the valve. That actually, the symptoms of a stenotic valve are very similar to symptoms of a heart attack. So, and especially if it's in the aortic position, something called aortic stenosis. And it's very common as we get older with similar risk factors for coronary artery disease. It's the same risk factors that can cause aortic stenosis, so high blood pressure, high cholesterol, age. So all those things cause this thickening of the valve. And sometimes we don't know what causes it. It has nothing to do with you. It's just the genetics. So if that happens and you have a stenosis, you may present with chest pain, shortness of breath, thinking it's a heart attack. And in fact, you can have a heart attack from a narrowed valve. So that is actually a sign of a narrowed valve. But the mechanism is different than a ruptured plaque or occlusion of the heart. It's rather a problem with pumping forward flow out of the heart. And we do have a program at UCLA in our cath lab where we can now replace that valve, like Dr. Horwich is saying, without opening the chest, doing it the same way we do with putting stents in, by actually implanting a new valve endovascularly or percutaneously. And that's a program that we've just done 50 patients at UCLA, and it's a very exciting technology that we're developing here.
Who has oh, there you go. Sorry.
I have a question on the cholesterol levels. And it is true that unless you go out of your way to ask for the cholesterol level reading, doctors don't give it. They'll be giving me a blood test for a whole bunch of things, and unless I ask for what is the cholesterol while you're at it, they won't just automatically put it on. The question I have is that at what point, if you have a basically healthy lifestyle, as I do, and no weight problem or anything like that, all of a sudden from 1 year to the next, between being 40 and being 41, my cholesterol level at my annual physical showed this incredible spike. We have a history of heart disease in the family. I started using Lipitor. It worked. I didn't have any problems adjusting to it. The cholesterol level came down. Lifestyle choices and food were not all that radically different. Just more aware. What is it that causes the spike all of a sudden?
We are hardwired to do that. So cholesterol is something that's related to things like diet, but only about 25% of the cholesterol in your body comes from diet. The other 75% of it, you're hardwired to produce. And often you're hardwired to produce a certain amount and a certain amount that goes up every year. Other things like hormones absolutely affect the cholesterol. So when you're becoming premenopausal, the loss of estrogen makes the cholesterol jump up. So around the time of the menopause, perimenopause, it's very common. We all see a jump in our cholesterol.
Also things like diabetes, disorders, or any other endocrine disorders can cause changes as we get older in our lipid metabolism as well. So we do screen for other causes as well.
Do you stay on statins for the rest of your life? I mean, if I go off, does the cholesterol come back up?
It'll rebound a little bit higher and then settle down to its usual level.
A question about the time frame. Let's say you're experiencing some of those symptoms, many of them, a couple of them. How long does one have before it's going to be really too late in terms of a heart attack or a stroke?
If you're alive and you're having symptoms, you make it to the hospital. but there is data.
Time
But
is
you've
muscle.
got
So
20
90
minutes
so
to get.
90 right. So there's some data that basically if you present within 90 minutes, you have improved survival, and they're looking at even 60 minutes being even better than 90 minutes, although the data is not very different between 60 and 90 minutes. Beyond 4 hours to 6 hours, you start to see an immediate drop in the mortality benefit, or the gain of revascularization or coming in and having your artery fixed. And then beyond 12 to 24 hours, at that point, it does become too late. And now if we're talking about a very rare situation, which is a situation where you have a 100% occlusion in the vessel. If your vessel is not 100% occlusion, that doesn't mean that you're not having a heart attack. There are different grades of heart attack. So that heart attack, you would receive benefit at any point. So it isn't really up to you to decide timing. I would just say, go to the hospital.
I would say as soon as
and don't worry
possible,
about the
'cause-
benefit, because there will be benefit.
And time is muscle.
And time is muscle. So.
And if it's a stroke, time is even more critical potentially, because they will only give you, excuse me, the clot-busting drugs if you're within, I think it's an hour of the onset of symptoms. Okay, so these are medications stronger than aspirin that can go in and help dissolve a clot. And in an ideal situation, as happened with my great aunt last year, they can start improving very quickly, and you can see a little bit less fatigue. You can see some of the things, but you need to be able to know exactly when the symptoms started and to know that it works. Otherwise, there's a risk that they're going to give you those and it's going to make it worse. So you need to get in quickly so that they can try to manage a stroke and understand what's going on. And the sooner that you've called for an ambulance, the sooner you've gotten in for care, the better reliability they have on what is that window. Is it well documented? Is it safe to try the best treatment that they have?
Well, thank you. And then one other thing, I'd heard that in addition to the things you mentioned about a stroke patient, asking the person to stick their tongue out
Exactly.
is the fourth thing.
Exactly. So any of the muscles, yes. Okay.
Thank you.
Hi. My father, 84, he was very healthy. Check with the doctor at UCLA, nothing wrong with the heart. All of a sudden, last year in May, he got up early in the morning, 5:30. He had a heart attack. He didn't know it was a heart attack. Very bad pain. Waited, had breakfast, going to the center where the elderly go, having another breakfast. Nothing until 10:30 in the morning. And the only reason that he was sent to emergency because the lady asked her, "You were pale," and he said, "I had some discomfort." At 11 o'clock, emergency room called me, "Your father had a heart attack." And they wanted to do an angio to do stent, but he would not accept it. He waited until the next day. Next day, I had to go through a lot of trouble until he got the stent, and he was under surgery for they wanted to do open heart, but because he was older, they just did, they said it was terrible. The artery was so badly clogged. They didn't know what to do. Finally, they put 4 or 5 stents, and one of them was terribly bad. They couldn't do anything. And the doctor emergency room was screaming, why didn't they give him the statin? Okay, they never gave him statin at UCLA, but however, my mother, she's 88, and she's under care of a doctor at UCLA that she never had high cholesterol. But the doctor is giving him Lipitor, giving her Lipitor for years. And even though I'm telling him that Lipitor can cause, I said, no, she has to take it, I'm taking it. Now, for almost 15 years, she's taking Lipitor, now 10 milligram, and he's not taking it off. The question in my mind, which I ask others, and I never got to an answer, that if my father or even my mom that is taking it, is this the reason that she has no blockage in the heart and she's very healthy? I don't know.
So what all of us can tell you is that these statin medications have changed the natural history of atherosclerotic heart disease. So we know there are risks and benefits to every medication, but these medications have absolutely changed the natural history. My own father had a heart attack at age of 59. I was in medical school, And at that time, the standard teaching was, if you have a heart attack at 59, I don't know when you're going to die, but it's going to be pretty soon, and it's going to be a heart attack that gets you. Well, he just turned 86, and he's good because his doctor started him on a statin that day. We really have seen the disease change.
The incidence of myocardial infarctions has gone down dramatically, making my nights more restful. Thank you. But I would say that part of that has to do, a large part of that has to do with statins. And so, it's never only one answer, though. I have to just so you know, it's not just because she's on a statin that she has no disease. It's the whole, there's genetics, there's age, there's blood pressure, there's just about probably 50 different reasons why people have heart disease. We maybe know 5 of them. So we're getting there, but statins is a huge breakthrough for heart disease, and aspirin.
And we'll have this be the last question, and we'll obviously have our panelists at the reception afterwards. So I know you had a question.
I was going to ask, what can we do with our genetic?
Choose your parents carefully.
We are using genetic testing more and more in cardiovascular disease. And I think, in 10 years we'll be using it even more. You'll be getting a genetic test, and your kids will be tested to see if they have the mutation that you have. And if they do, they will be, treated preventively to try to prevent. And right now we're using it more in the cardiomyopathies, diseases like hypertrophic cardiomyopathy or dilated cardiomyopathy. But I think pretty soon we'll be having it for coronary artery disease also.
And identifying the genetics is going to help identify those patients at risk before they get the disease, so the genotype precedes the phenotype. So it will be very useful to have that information, because you may find out that you have a tendency to have a heart attack, and if you know that at the age of 20 and you start an exercise program and you watch your cholesterol and you watch your blood pressure and you don't smoke,
You should do those things anyway.
But those may identify those patients even sooner. And it's very important in your heart disease has been shown to start at very, 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 very younger and younger ages, even children. So it's a disease of all ages.
Okay, so they're telling us it's about time, but I wanted to let everyone know that we couldn't get to all the questions, but we will have question cards upstairs, and we have all committed to answer each and every one of those cards. So leave us your email or a phone number and the question you'd like us to answer, and we will get to each and every one of them. And finally, the comment cards upstairs will say, how did we do, and what would you like to see us do next? So please fill those out so we know how to best serve you. Now I'd like to invite Michelle Jacobson up to the stage. Michelle has been instrumental in putting this day together, and I'd like to present her with some flowers. Thank you. Thank you, Michelle. And Michelle, she has been so helpful in trying to get our heart health program up and running, and she will give you some information about ways perhaps you would like to help. And I just want to say thank you for helping us do this.
Well, this was a surprise. I'm the Director of Development for the Department of Medicine, and it's my pleasure to ensure that the fabulous clinicians and doctors and researchers here have the resources they need to do what they need to do, the research. We've heard tonight of so much advances in the research, but clearly there's a lot more to do. That's telling us.
Sorry.
So I want to thank you for coming tonight, and I want to extend another invitation and to invite you to partner with us to impact the future of women's heart health, and together we can make a difference that will last a lifetime.